Um, so when we know that many restorations now are debonding, maybe we can do better on the bonding procedure to prevent debonding of these restorations. Um, so if a restoration debonds, you will lose that restoration. Sometimes they break. So sometimes an empress crown may come loose, and the patient may bite on it, knowing that it's not knowing that it's loosened up, and then they will break it. So fracture sometimes can result from loss of retention. And sometimes the restoration starts loosening up and you get some micro leakage and marginal discoloration. And some patients present with hypersensitivity from a loose restoration or even recurrent caries. Um, when we see fracture in all ceramic restoration, most of the time it is related to preparation guidelines being violated. So if you're using Empress or Emax or even zirconia, make sure you observe the minimum thickness of the restoration, provide the minimum clearance recommended by the manufacturer, or you might be dealing with the patient-related factors like prior functional habits. So know your limitations and know the contraindications of some ceramic materials that you're using. Discoloration, we did touch on internalized discoloration, and this emerged as a more current topic because we're doing more all ceramic restorations. So this kind of discoloration, it may have happened in the past, but you wouldn't see it underneath a metal ceramic crown or a metal crown, right? But now that we're using more and more all ceramic restoration, we cannot afford this kind of discoloration. And this internalized discoloration, and I did post a reading for you as an optional reading when we talked about hemostatic agents. And this can be related to the use of ferric sulfate and the incorporation of iron and sulfur into the tubules, so in the presence of certain bacteria. This can also be the result of bleeding. If you entrap some RBCs during cementation, then RBCs can be a source of iron as well, just like ferric sulfate, and that will result in such discoloration. So this is just to pay extra attention to the cementation process and to make sure that um, you avoid using something like ferric sulfate in the aesthetic zone, especially when planning all ceramic restoration. Yes.
Dr. Kibawi, yeah, I just had a question.
Okay.
So ferric sulfate is, if we still use it, I mean, I think it was the best of the hemostatic agents that could control bleeding.
Sure.
Right. So, like, I mean, wouldn't that kind of like minimize the bleeding that could possibly come in the RBCs that could possibly stay in the tooth?
Sure.
And if we use it like, like judiciously, could it like be still used in the anterior, or is it like really just like it'll
I
always stain?
Thank you. I avoid using it in the anterior zone, in the aesthetic zone, if I'm using all ceramic restoration. So I would focus my energy and effort there on controlling the reason for the inflamed gingiva. So really, you have full control with the patient. Patient with high aesthetic demand should also, put in the effort in maintaining good oral hygiene. And with that, if you don't have gingivitis, it is so easy to achieve in the healthy tissue that will not give you trouble during the impression. It starts with good preparation, good provisional adaptation, excess cement cleanup, the temporary cement, and good oral hygiene instruction, good access to hygiene, good patient motivation. So I wouldn't really be even talking about the case where I cannot control bleeding, we're in the aesthetic zone and I have to use ferric sulfate because, I think we need to take a step back and do better with whatever with the provisional and with oral hygiene. So yes, I agree with you. Ferric sulfate is the most effective, and I use it when I'm desperate. But I will also, at any cost, avoid using it in the aesthetic zone if I'm using a translucent restoration. The gel form of aluminum chloride or Hemident is more effective than the water form because you can apply it locally, but you can also use some injection of anesthesia into the bleeding areas, and the epinephrine as part of your anesthesia really helps sometimes contain the bleeding. But again, if we're dealing with a disastrous situation of inflamed bleedy tissue, then I probably wouldn't want to be going there anyway, right? Sorry that I didn't give you a perfect answer, but you
I
know?
got the idea. Thank you.
Yeah, okay, wonderful. Um, so one other thing we want to quickly go over is wear of natural teeth. I want you to know that rough ceramic surface is the most abrasive to natural teeth. So when I see something like this in a patient's mouth, I see severe wear or abrasion on teeth. The first thing I do is look upstairs. I look at the opposing teeth, and of course, I see an old ceramic restoration, maybe a PFM crown that was adjusted intraorally because it was high, but then nobody bothered to polish it. Rough porcelain is extremely, extremely, extremely abrasive. So please, 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 if you have to do any occlusal adjustment of a restoration after it has been cemented, first of all, you're going to be using a fine diamond burr, a red stripe fine diamond burr with water. We're going to talk about that when we talk about adjustment of the restorations. But whenever you're working on ceramic, you don't want to build up heat. Heat can result in stress buildup within the ceramic restoration, resulting in fracture. So, as a rule, you want to be adjusting with a fine diamond with water cooling, right? But once you're done with the adjustment, you have to go through the polishing um, steps to leave behind a highly polished surface. And this is the Dialite. It's a Brasseler Dialite kit. There's an extraoral kit, and this is the intraoral kit, normally a latch handpiece. Um, and you go blue, pink, gray. Gray will give you the final polish and luster. Blue is the first step, so it's really for finishing. You can reshape, if you can finish the occlusal adjustment. If you have a slight high spot, you can take it down with the blue. And then pink starts the polishing process, and then the gray will give you the final polish. This is an ABC in dentistry. This is bread and butter that you will be using. So you're gonna know what the Brasseler Dialite system is. You need to know the sequence: blue, pink, gray, um, and then make sure that you polish intraorally. Avoid the use of a coarse diamond. In the basic principles of designing and all ceramic restoration, it's also important that the centric contact of the occlusal contact on that restoration be on an area of the restoration that is supported by tooth structure. This goes back to the concept of placing ceramic under compression. So if there's an occlusal contact there, hopefully and ideally that portion is supported by tooth structure. So hopefully you're not dealing with a short preparation that ends right here, right? And this whole thing is ceramic. That means that the ceramic where the occlusal contact is doesn't have any support to place it under compression, which results in fracture. Jenna, gonna lean on you one more time.
Okay. Be critical when evaluating your work. Learn from others, including your technician. Success of all ceramic restorations depends on the clinician's ability to select the appropriate material, manufacturing technique, and cementation bonding procedure that would best match intraoral conditions and aesthetic requirements.
Thank you. So I will skip the recap because really I went over everything again today, but you do have the slides. I think I will end here. You guys have any questions?